Hello, this is Jennifer, and I'm going to be the moderator for today's webinar. We're going to give everyone until about 3 past the hour to join, and then we'll get started. Hello again. For those of you who have just joined, my name is Jennifer, and I'm going to be your moderator for today's webinar. We are excited to present to you our Health Prime COVID-19 Getting Paid for Non-Face-to-Face and Telehealth Visits today. Before we get started, there are a few housekeeping items to go over. Questions you have for us are addressed via using the Q&A button at the bottom of the screen. You can submit your questions throughout the presentation, and they will be addressed at the end of the presentation. Any questions that we were unable to get to during this presentation, we do have your contact information and will respond. Questions we have for you are addressed using polls. A poll will be conducted before and after the presentation. We encourage you participate so that we can focus on areas of interest. Before introducing you to Caroline Balestra, I'm going to go ahead and launch the first set of poll questions. Our first poll is in regards to your confidence in your current coding and billing for non-face-to-face visits and your confidence in your current reimbursement for non-face-to-face visits. Wonderful. Thank you for your participation. Caroline Balestra has 8 years of experience as a practice administrator and an additional 13 years focused on revenue cycle management and analysis. She currently works as a business process analyst at Health Prime, where she coaches team members and clients on best practices, coding, and practice optimization. Without further ado, I'm going to turn it over to Caroline for the presentation.
Thanks, Jennifer. Hi, everyone, and thanks for joining me today as I walk through ways to ensure you get paid for non-face-to-face visits, telehealth, and other types of visits during COVID-19. The topics we'll cover today include definitions of telehealth and telemedicine, Waiver 1135, Medicare guidelines, coding and documentation, private payers and other payers, and controlled substance non-face-to-face visits and other types of visits. We'll then touch on proper diagnosis codes for COVID-related visits and review my list of helpful resources I've provided to help you all with coding for multiple types of visits. Let's go ahead and get started. First, let's clarify the differences in these. So what is telemedicine? Telemedicine describes the use of technology to deliver care at a distance. A physician in one location uses a telecommunications infrastructure to deliver care to a patient at a distant site. What is telehealth? Telehealth is closely associated with telemedicine. It's often used to encompass a broader definition of remote healthcare that does not always involve clinical services. Video conferencing, transmission of still images, e-health, including patient portals, are all considered part of telemedicine and telehealth. So what's the difference, you ask? Well, telehealth is different from telemedicine in that it refers to a broader scope of remote healthcare services than telemedicine. So more recently, since the widespread use of telehealth and the telehealth and the telemedicine terms have become interchangeable, there's not really any difference anymore. Let's talk a bit about the Public Health Emergency, or PHE Waiver 1135. Under Section 1135 of the Social Security Act, the Secretary of Health and Human Services may temporarily waive or modify certain Medicare, Medicaid, and Children's Health Insurance Program, or CHIP, requirements to ensure that sufficient healthcare items and services are available to meet the needs of individuals enrolled in Social Security Act programs in the emergency area and emergency time periods, and that providers who provide such services in good faith can be reimbursed and exempted from sanctions, of course, as long as they are absent any determination of fraud and abuse. Two requirements exist. The President must first have declared an emergency or disaster under either the Stafford Act or the National Emergencies Act. Secondly, the Secretary must have declared a public health emergency under Section 319 of the Public Health Service Act. So with these requirements, the President must first act and then the Secretary. Both declarations must be made and it must be done in order. So, because this is a Social Security Act that makes these exemptions for Medicare, commercial payers do not have to follow them at all. Private payers can cooperate, but they're not required to do so. Medicare said that starting on March 6, 2020, a patient does not have to be in a facility or a rural shortage area to be treated in a face-to-face private communication. After March 6 of last year, the patient can be in their home or another location when conducting a non-face-to-face visit. However, it must be an audio-video one-to-one connection like Zoom, Skype, or other software applications. And you must let the patient know if you're not using a secure connection. With this part of the emergency waiver, most recent guidelines and laws now affect private payers and cost share where COVID testing is ordered or rolled out. In these cases, testing does have to be paid at 100% by the payer. When the payer tells you cost share has been waived, it could mean either that they will not pay 100%, but you are not required to bill the patient if it creates a hardship for that patient. Or It could mean that the cost share could pay at 100% and include the patient's portion. You always want to be sure that you understand how the payer processes any cost share and what that payer requires. Another important part of the 1135 waiver to understand is that Health and Human Services will not audit for established versus new patient status of the patient visit. So if it's not Medicare or Medicaid, you will want to understand if the patient's policy covers telehealth visits by telephone or audio-visual link, both or none of these. Some only cover for established patient visits, not new patient visits. Some only cover for MDs and not other types of providers. And then some will only cover audio-visual links and not telephone calls. It's important to understand what the payer allows to ensure you know if you will receive reimbursement for the services you render. Under this waiver, the nature of the telehealth visit does not have to be related to COVID-19 for this to apply. I'm sorry, my slide is stuck. One moment. Uh-oh, we're just spinning. Well, I've never had this happen before. Okay, let's see if I can bring it up on a different screen here. One moment, sorry. Okay, back in action. So Medicare Advantage plans are not Medicare, right? These plans are required to offer beneficiaries at least the same benefits they receive from regular fee-for-service Medicare, but they function as commercial private payers. Some of these commercial plans will follow fee-for-service Medicare guidelines, while others will not. Straight Medicare fee-for-service will pay physicians for telehealth services at the same rate as an in-person visit for all diagnoses, not just services related to COVID-19. It's important to understand the requirements for the specific commercial Medicare Advantage plan that you're working with. There are some important questions to ask of commercial payers when it comes to telehealth coverage. These questions will help you understand the benefit the patient plan offers. These include effective dates, covered services, who can provide such services, how they're billed, do I use telehealth or office visit codes, what modifiers are they wanting used, what is the correct telehealth place of service code they want submitted, and are telehealth services only covered during COVID? Understanding the plan benefits will allow for correct coding, submission, and will help to ensure payment for services. Even during a public health emergency, telehealth requires real-time audio and video. Only services on the telehealth code list are to be used, and all criteria for each CPT must be met. Previously, Medicare Place of Service 02 for telehealth was paid at the facility rate, but new guidance states that the provider can choose to use whichever place of service code is most appropriate, and then apply a 95 modifier where applicable. While virtual check-in, online services, and phone calls are not considered telehealth, they are what we call CTBS, or communication technology-based services, which are payable, just not as a telehealth service. Here's a chart that I put together that outlines Medicare telehealth, virtual check-in, and e-visits, what the service is all about, the codes to use, and the relationship to the provider, meaning if it's a new or established patient visit. All codes shown here are reimbursable services under CMS guidelines. Okay, so here's a list of most common modifiers for telehealth. The 95 modifier is the one we just touched on previously, and this is for a synchronous telemedicine visit, which must be a live audio-video linkage connection and cannot be a store and forward, as they call it. And they're telling us to use this in lieu of place of service 02. GQ. This modifier is if the patient is in Alaska or Hawaii and the doctor is in California, for example. They will allow use of an asynchronous telecommunication system to be used for only patients in those two locations. GO is used for telemedicine for symptoms of acute stroke. And so now CMS has also stated that there is no need for any modifier to be used for place of service 02. But there are some contracts and payers that want you to use the modifier CR, which is for the catastrophe and or disaster related services. Medicare has outlined, which is new to 2021 CPT coding, that the evaluation and management level selection for these services, when furnished via telehealth, can be based on medical decision making or time and can be used for telehealth services. New or established CPT codes can be used and will no longer require the components that reference typical face-to-face time. Instead, each service includes a medically appropriate history and or physical examination. And then the code selection will be based on the MDM level or total time spent on that date of the encounter. Time documentation is required with this new rule. There are some time activities that are included, such as preparation to see the patient, which includes review of tests or similar activities, performing the exam, counseling or educating the patient, caregiver, or family, ordering medications or testing, and care coordination, among a few of the activities. If the payer will pay for patient visits new or established, and it's covered under your malpractice policy, you will want to ensure that documentation is complete and based on your medical decision making and includes establishing a diagnosis, assessing the status of a condition, and or selecting a management option. 4 types of medical decision making are recognized, and they consist of straightforward, low, moderate, and high levels of decision making. This concept of MDM no longer applies to CPT 99211 as this code was deleted. Remember that the 3 components of medical decision making are the problem point, which is the number and complexity of problems addressed during one visit, data point, which is the amount and or complexity of the data to be reviewed and analyzed, and risk, which represents the risk of complications, morbidity, and or mortality of the patient management decisions made at that visit. An example of straightforward medical decision making would be using 99202 or 99212, where problems are minimal or limited to one minor problem. There is little to no data to be reviewed, and the risk of complications are minimal as well. If you'd like to review the E&M coding changes for 2021 in more detail, please visit our website and navigate to the recorded webinar from Wednesday, December 9th, 2020 for a refresher if needed. For coding and documentation, I've heard many ask questions like, how can I document an exam without laying hands on the patient? Well, there are some things that you can utilize to help with medical decision making during your telehealth visit. It's very possible to perform an exam just with observation and talking with the patient during a real-time audio-video conference. For example, through your screen, you can see the general appearance of the patient, Or think about how that appearance might be altered when you observe, for example, the patient's sclera, which refers to the whites of the eyes. You may be able to see if the patient has yellowing, for example. You may also observe the patient's skin tone by looking at their face and hands to see if there are any rashes or other skin issues. Additionally, a patient's mental status can be observed by just talking with the patient. So you absolutely can perform an exam via telehealth. In my examples, you can see that there is a lot of exam that can be done just by observing and talking with the patient. But please remember that E&M visits since January 1st, 2021 will require MDM or time documentation and no longer require history or exam. Inpatient and subsequent care has been added to telehealth. Talking to nursing staff and other physicians without the patient is not covered under telehealth. Like all telehealth services, this requires an audio and video link with the patient, not the facility or its staff. Always remember to check with private payers to best understand if they will even cover telehealth via audio and video linkage with the patient in these types of settings. Not all payers will cover inpatient telehealth. Okay, let's talk a little bit about interprofessional internet consultations. It's a mouthful. Now, it's important to point out that this is not telehealth. This is something I think many doctors were doing, but now with the current demands, you can now bill for these without face-to-face visits. CMS recognizes and pays for 6 codes for interprofessional consults. Codes 99446 through 449, 99451, and 99452. And for codes 99446 through 449 and 99451, the CPT definition specifically says consulting physician, whereas 99452 does not specify that the consultant must be a physician. So technically, this would allow for other qualified health professional to use this code. These codes have other guidelines that are important to understand, such as the patient may be a new or established patient to the consulting provider for a new or existing problem. The consulting provider may not have had a face-to-face service with the patient in the last 14 days and may not bill this service if their review leads to a face-to-face service with the patient within the next 14 days. These don't necessarily have to be on an inpatient, but that is where they are used a lot now due to lack of personal protection equipment and doctors not being able to see the patient in person. Some private payers do not cover these at all. Just remember that specific CPT codes may have certain requirements, including a written and/or verbal report to the requesting physician as well. These CPT codes can certainly be billed, but not as telemedicine or telehealth type of visit. You would use the appropriate place of service, but again, it's not 02, as this is not permitted. It represents telehealth. During this public health emergency, the critical care codes 99291 and 99292 were also added to the list of accepted telehealth codes. The other requirements must still be met, such as instability of the patient, complexity of medical decision-making, and interventions, including time spent, must be a minimum of 30 minutes. The place of service should be reported as the applicable site of care. Okay, so far we've talked about a few different types of visits where telehealth and telemedicine can or cannot be involved. Let's look at hospital visit service codes. During this PHE or public health emergency, the hospital visit codes 99221 through 99223 and 99231 through 233, including discharge CPTs 99238 through 239, were added to the list of accepted telehealth codes. The other requirements, again, must still be met, and modifier 95 or GT should be used. I do have this amazing tool I'll share with everyone at the end of the presentation that provides guidance, just like you see here, where it's per specialty or type of telehealth service you're providing. Next, let's talk a little bit about preventative medicine. Medicare annual wellness visits are on the allowed list of CPTs. CMS has stated that self-reported vitals may be used when a beneficiary is at home and has access to the types of equipment they would need to self-report vitals. During COVID, providers can perform annual wellness visits via telehealth and file appropriate codes related to these services. Telehealth claims must include HCPCS G0439 or a federally qualified health clinic code of G0468 and be billed with a place of service code of 02 or 11 with modifiers GT or 95. Body mass index and blood pressure results for the patients will not be required for these claims. Weight, blood pressure, or other routine measurements can be self-reported or deferred. There are other requirements for these visits. They are: providers should already have an established relationship with the patient in order to do a wellness visit via telehealth. The patient must virtually consent to using telehealth for a wellness visit, and the consent must be documented in the medical record prior to the visit. And lastly, visits are covered once per calendar year. For additional information on this topic, again, I provided that resource that we'll go over at the end of the presentation. It'll allow you to review all components of telehealth and for annual wellness visits per the CMS guidelines. With audio only, you have these CPT codes to utilize. Prior to March 2020, the way Medicare looked at this was, if you needed more than 1 to 15 minutes with the physician, then you need to be seen. But with COVID and this public health emergency, they've changed this. They said, under the circumstances, we understand these longer phone calls, so codes now allow for this, and fees were adjusted to allow for the time spent. For non-physician types of providers, the only difference is that they must use different CPT codes for telephone services they provide. Again, these are not telehealth or telemedicine, but are billable as telephone services, which are time-based. You can see here that I've pulled some Medicare allowables just so you can see what that reimbursement looks like. Okay, controlled substances. State laws for most states requires a face-to-face service with the patient to give a controlled substance prescription, but that has been waived as part of the 1135 waiver. These visits can now be done via telehealth, and controlled substance prescriptions issued to the patient. They can be issued to the patient as long as the guidelines for your federal and state laws are followed. Medicare and Medicare Advantage plans cover the testing to determine if you have COVID with no cost to the patient or plan member. If your office is testing for COVID, there are a couple of codes that can be used, but this is important. It's really important to remember that these are laboratory test codes, and guidelines therefore require that you are performing the lab test in order to bill the code. If you're only collecting the specimen, collection of a swab does not warrant billing the actual test using 87635, for example. Some payers may pay a handling fee for collection of a specimen using a 99000, a G2023, or G2024, but Medicare does not. It's important to know the plan benefits when you're wanting to routinely bill using these types of codes. Medicare does not pay a handling fee unless you are an independent lab and you're traveling to pick up, obtain, and return the specimen to the laboratory. Okay, homebound status does not need to be documented anymore as of 1/1/19 due to home visits being added to telehealth services. I'm sure you're asking how to distinguish a telehealth visit from a home visit. There's really no good answer to this. Medicare states that use of an E&M code that best describes the care being provided and the status of the patient should always be used. Okay, for all visits not related to COVID, you'll document and code as normal. The diagnosis coding guidelines state that all documented conditions that coexist at the time of the encounter and require or affect the patient care, management, or treatment should all be coded for that visit. Effective April 1st, 2020, we are to use ICD-10 code U07.1 for the virus identified via a lab test and confirmed to be COVID-19. ICD-10 code U07.2 should be used where the lab test is inconclusive or not available, or where the virus was not identified. Both U07.1 and U07.2 may be used for mortality coding as cause of death. If coronavirus is not confirmed, you'll code upon the physician's judgment or documentation. Just a quick reminder about the diagnosis codes when looking them up is that any word you see in parentheses, like here where it shows suspected, it's called a non-essential modifier. What this means is that if the word is there, the statement is valid. But if the word is not there, the statement is also valid. Just to wrap up, it's important to look at guidelines for each payer. Remember that documentation still has to fulfill the requirements of the code used. All diagnosis codes should be documented at each encounter. And finally, it's necessary to remember to store your encounter information where it's accessible for the provider and the payer should a review be needed. So here's the list of resources to help you out. The first resource has the option to click to see what specific payer coding requirements are. I encourage you to check this out. It's extremely helpful. The next one is going to give you access to provider guides for numerous tools like billing for telehealth during COVID, policy changes, preparing patients for telehealth, and more. I included a YouTube video, which is from MLN on telehealth coverage and payment of services. And then I also included a web link where you can find most everything discussed in today's presentation, including some additional billing tips and links. I also added an interactive link for MLN preventative services, which provides an in-depth guide for Medicare wellness services and a telehealth fact sheet. And I've also provided more info for everyone on interprofessional consults. But lastly, which is my favorite, is the coding guide for all services provided via telehealth. This is provided by AMA, and it's a great tool for any type of service, how to code, when to use the code, modifier, etc. Please check it out once this has been provided on our website for everyone. I know this has been a ton of information today, but I hope you found some of it helpful. Thanks again for joining me today. I'll go ahead and turn this back over to Jennifer for any questions.
Thank you, Caroline. Finally, we do have two additional poll questions for you. I'm going to place those on the screen now. Wonderful. Thank you for participating in the poll. We do have a few questions. So Caroline, I'm going to go ahead and start by asking the first question that we did receive.
Okay.
The first question states, are we still considered to be in a public health emergency since it's been almost a whole year since this began?
Yes. Unfortunately, COVID-19, as we all know, is an ongoing issue that's still considered to be an active public health emergency. This means that the waiver 1135 is still in effect and available.
Okay, wonderful. Thank you. And our second question is, when I am coding a new patient visit, do I document the face-to-face time during our video/audio conference?
Okay, so the new 2021 E&M coding requirements no longer require a component for what we previously called face-to-face time. The visits do require time documented, but the time can include what they call time activities. Those can be things like we talked about, preparation to see a patient, review of testing, or other similar activities, time performing the exam, or counseling, just to name a few examples. They also require proper level of medical decision making and risk assessment, but do not actually call for the time on the video audio conference call to be documented.
Okay, wonderful. Thank you. We want to thank everyone for your participation in today's webinar. And if you have any questions and you are a customer, please reach out to your operations consultant for any additional questions. And if you are a prospective customer wanting more information regarding COVID-19 and getting paid for non-face-to-face and telehealth visits, or just questions in general, you can email us at marketing@hpiinc.com or visit us at www.hpiinc.com. Thank you and have a wonderful day.